this lesson, I'm going to be talking about meconium aspiration and help you understand the clinical presentation and your role for caring for this patient. So first, I just want to explain the terminology. So this will be a little bit easier to understand for you. So meconium, this is that first stool that they have, or maybe first couple. And it's described as black, tarry. Okay, so that's important. It's very tarry, very sticky. If you've ever seen this first stool, you know it can take a lot of wipes just to get it off because it is so stuck to the skin. So you can see in this image, the meconium stool, it's so thick, right? And just sticky. You can see how it's all stuck together. So imagine that in your lungs. Gross, right? So sometimes these babies are going to expel this stool before they are born. So they expel it in utero. We don't want to see that. So when they expel it in utero prior to delivery, which happens a lot with these post-term babies, or if they get under any stress, they can stool in the uterus. So when this happens, it's in the amniotic fluid. Now remember, sometimes these babies are taking these practice breaths and they're getting it, or sometimes they're born and they take that first breath and then they aspirate it. So they aspirate that meconium into the lungs, and that's when it becomes a problem. So the baby either does those practice breaths and gets it in there, or that first breath at delivery. So it's not good. There's stool in the lungs and it just doesn't belong there, right? So now let's look at what our assessment's going to look like for this. All right, what do you think this baby's going to look like? There's going to be immediate respiratory distress. So this is not like an hour later, they're in trouble. It is immediate. They have respiratory distress occur. There is a sticky substance on the lungs, so it's going to make it hard to breathe. The baby's first breath that they take, that cry that they take, is going to pop open those lungs and help them expand. But if you have meconium aspirated in the lungs, then that meconium is going to be sticky in there and it's going to keep those lungs stuck together so they can't pop open and expand and do what they're supposed to do with exchanging oxygen properly. So on assessment, we might see some cyanosis, that grunting sound that they do to help try to pop their lungs open, and then an increased respiratory rate because they're trying so hard to do what they're supposed to do. Also, yellow, green, brown amniotic fluid. So amniotic fluid is supposed to be clear, right? Well, if your patient has a yellow, green, or brown tinge to their amniotic fluid, then we know that there's meconium. Okay, so this equals that meconium has happened. And then when they are born, you might notice discoloration to their cord, the umbilical cord, their nails, their tongue, because they've been drinking it. So it gets a little bit green, brown stained on the cord and the nails. And that just means they're meconium stained. Okay, our management is going to be quick action. We need to be fast because with meconium aspiration it happens fast. So suction needs to happen immediately. And remember, we want to do mouth first, then the nares. So we want to make sure we clear out that mouth before they take that first big breath. Because remember, they're going to inhale anything that they have in their mouth back into their, hopefully not, but they could, into their lungs. So mouth and then the nares. There's been recent practice changes between stimulating versus intubation at delivery. So it used to be that at delivery, the baby would be born and immediately go to the warmer and be intubated. And then they would try to do suction to get the meconium out before they took a big breath. Now they're saying that a lot of times that it's too late. The aspiration's already occurred because of those practice breaths. So current practice is saying now to stimulate the baby. Just if they're vigorous on there, just stimulate, get them crying, and don't do the intubation. They found that with the intubation, it was depressing the infant and they were doing worse. So just that immediate stimulation now is what's recommended. Medications. So remember, they have stool in their lungs, and so we want to give them some antibiotics. They're going to get a lot of antibiotics if they've aspirated. So they'll get that. ECMO. Now, this is in severe cases, but they might do ECMO in a NICU, and that's just to help rest those lungs. So we had a nurse deliver at our hospital a labor nurse. She delivered her baby at our hospital, and that baby had meconium aspiration, and they had never been so close to coding that baby over and over and over. That baby was so sick. So they eventually transferred the baby to one of our sister hospitals, and the baby did receive ECMO and now is fine, but it just helps, a machine is breathing for them, circulating through the ECMO machine. So it'll rest the lungs. So they might need that. And then education. So our education piece for this is that this is going to require a NICU stay if the aspiration has occurred. And then it also might require education that the NICU team might be present at delivery if meconium was seen in the amniotic fluid, just to have extra hands on deck for the delivery. Our concepts for meconium aspiration are going to be elimination and oxygenation, because meconium is an elimination, and oxygenation because this becomes our biggest problem for these babies. All right, so these key points, if you'll remember them, then you should be set. So just remember, meconium is sticky. So it's going to keep those lungs stuck together and they can't pop open. So the baby aspirates the meconium, the lungs get stuck, and then we're going to have difficulty breathing. And then infection. Stool is where it shouldn't be, so we need to treat with antibiotics to help treat that and prevent infection. Make sure you check out all the resources attached to this lesson, review your key points. Now go out and be your best selves today, and as always, happy nursing.